This meeting is now being recorded.
And we're going to share the screen, so you should be seeing it shortly.
Sorry. Should have done that earlier. Okay, present. All right. Are you all seeing the PowerPoint?
Yes.
Okay. Someone is. That's all I care about. Start.
You win. All right. So we have a little bit of a potpourri of a hit call today. We are
going to allow. Sorry.
Yes. Okay. So we're going to talk about the continuation application, meaning what we need to do to determine how to fund you next year. It sounds scarier than it is. We're going to talk a little bit about WWC contract names and what we're calling various contracts now that we have so many. And we're going to talk about some policy updates that have come from the CDC, the National Breast and Cervical Cancer Early Detection Program. Remember *6 to mute yourselves. And then I just wanted to do one quick update that I thought of. I think this was in the WWC update this week, but just a note that womenswellnessconnection.org, that website, the content of that website previously, we had a really hard time changing it. So it has now transitioned that when you go to womenswellnessconnection.org or .com, it will send you to the CDPHE website. We've transferred over all the content of why you should get screened, how to find a provider, resources, that kind of thing. But just don't be surprised if you or your clients are seeing a totally different website. It's much more flexible for us now to update things like federal poverty level as they change. But I just wanted to make sure you knew that the womenswellnessconnection.org exists. It still works, that website, and it's still fine on all our marketing materials and stuff. You don't have to send them to the CDPHE website. It'll behind the scenes direct them to the updated website. If there's any questions about that, let us know, but just didn't want that to surprise anybody. So with that, I'm going to let Chris talk about continuation application.
Okay, thanks. So, some of you have been through this before in various versions of how we've done this. What we're going to do is post an application online as a survey, and it's not really an application. It's more of an information gathering piece. We will, and you'll have about a month to fill it out, and we're going to be asking some questions. The questions that will be on are in these three categories. Basically, we're going to ask who's filling this out, what's your agency name, and all that kind of stuff. And then we're going to ask probably the hardest question of all. What do you think is a reasonable goal for your agency for clients to be screened in fiscal year 2015?
Background noise. I'm going to go ahead and mute everybody because I'm hearing a side conversation.
Maybe someone's in their car.
Yeah.
All guests have been muted. You can unmute your line by pressing *6.
Okay. Thank you. So, if you have any questions, go ahead. You are muted now, so if you have a question, you can jump right in, but *6, your phone first to be unmuted. So we're going to ask you, what do you think is a reasonable goal? So what is your anticipated number of women to be served next fiscal year? And then the additional information will be questions like, what kind of changes do you foresee in your agency? Anything significant? Any changes that would cause significant increases or significant decreases to your clients served? So, for example, if the number you give us as your goal is significantly higher or lower than what you have done this year or last year, you may want to give us some information. Let us know if anything's happening. Maybe you have a new clinic. Maybe you know you're losing a provider. You know, there are a lot of things that could happen. So we're going to, agencies will have about a month to complete this. Then what happens is our staff looks at your goals, your anticipated goals. We look at what you've spent this year so far, and then we will basically determine your budget for next fiscal year. So we're going to take a look at your number, the number you've estimated, and come up with a dollar amount. And that'll be based on a cost per woman that is today, it's about $377 per cost per woman. So we're going to be basing it on that. And then you will receive a grant fund change letter in May or June for this, for your fiscal year 2015-2016 budget.
And that's because you all have multi-year contracts, so you don't need a new contract. We just have to add the funding to your contract.
Moving some funding around. So the timeline for this process is we're going to post the survey, and it's going to be a Survey Monkey, and it'll be available on March 25th, so watch your WWC update, your weekly newsletter for that link, and we'll keep it in there every week until the due date, which is April 22nd, which is a little bit after your April bill run. So you will have one more bill run to have, hopefully give you a better idea of what your screening numbers might be. And then we will notify you in early May about what your budget will be, and then the grant fund change letter process will begin. A heads up to care coordination grant program agencies. We will be doing something very similar, if not exactly the same, for that grant. But the timing is going to be a little later. So that one, watch for a survey to be available early May, and then it will be due after the May bill run. And that's for the Care Coordination Grant Program agencies. Are there any questions?
The multi-year contracts make it way easier than it used to be because you have a contract in place, so it's not about getting it signed by your board or executive director and making 3 copies and all that stuff. We just get to do the grant fund change letter.
And if you're a new agency, this would be the first time you're doing this. So this is to determine how many women you think you can serve. And it has to do with your budget for next year. Each year we do this process annually. And as a new agency, some of you found out that we do reallocations in February. So you know that while you may be asking for a certain number in February of 2016, we will be reallocating that budget as well. So you're using your best estimate of what you think you can serve.
Star 6 if you have any questions.
If you're not sure about your budget, Chris and I are always available to chat with you, to take a look at how many numbers that you've been screening. Your new normal should be a little more obvious this year than it was last year. You should have a better sense of how many women are under Medicaid, how many women are actually WWC eligible. Last year, I think we all guessed a lot, and this year there's a little bit more science behind it. You have an idea of how many women for your PAPs are on the 3-year cycle or 5-year cycle, you know, so you're going to be factoring in a lot of things. So look at your data, look at your history of what screenings have happened this year. You know, a lot of you keep separate spreadsheets that you can see when women need to be screened as well. Some of you have better electronic medical records than others as well, but we're here, and Q is able to provide some special data reports if you have some questions about screening intervals when people have been screened. So I think everyone will do much better this year. It's still a little bit of a guess, but I think there's a little bit more science involved this year.
That's a little bit tricky. All right. So, WWC contract names. This is Emily again. We've decided that WWC has grown. Let me go to this one. Some of you have seen this before. WWC used to just mean to us and to everybody and to the world, clinical services paying for breast and cervical cancer screening for uninsured and underinsured women. Now, in the last year or so, we've really broadened our focus. We're obviously still doing the clinical services here in this purple circle in the middle, but we're broadening our focus. So this diagram is a little bit like the socio-ecological model, where this clinical service, that's for individual women paying for their medical services. Then it goes out to care coordination, where we're making sure that women are getting the screenings they need by helping navigate them through the system, and doing case management. Obviously, we do that for the ones we're paying for PAPs and mammograms, but now some agencies are doing that for women where we're not the payment source for their PAPs and mammograms and clinical services. We're also doing clinic quality improvement, which I think many of you have participated in, where we're looking at your screening for breast and cervical cancer of all your clients, no matter their payment source, no matter their income, no matter their age or lawful presence status, and looking at implementing systems to improve screenings at a bigger level. And that the biggest level is awareness and education about breast and I'm talking with my hands that you all can't see me. Talking about awareness and education and why it's important to get breast and cervical cancer screening. So with this broadening focus of Women's Wellness Connection, we have confused ourselves and are starting to confuse the world, I think, by using the term WWC. So WWC now means all of this, which is great. We're doing a lot. Just one note, side note, these circles don't necessarily represent like the amount of effort, it's just the bigger picture. Yeah. So we have, and this is just some examples of the types of activities that are happening within the various things, and I can send this out separately too. I won't spend a lot of time there. So what we've talked about, which is really here, is being a little bit more explicit with our language, and we're hoping you all will help us in this, that when we're talking about when WWC actually pays for breast and cervical cancer screening, and obviously patient navigation as part of that, that we're calling those contracts WWC clinical services. They're also known as service delivery. I'm not sure we'll ever really or eventually we might get away from that, but I think that's what the contract says, service delivery. We just felt like clinical services actually explained it a little bit better than service delivery, because all of these things are a service that you're delivering. It's just a different kind of service. So that obviously has always been our biggest investment. Our investment this year, you'll see, is 45 agencies, and $2.7 million for clinical services. So then we also added WWC care coordination. So this is, we're trying to differentiate clinical services and care coordination. So that is 14 agencies and $239,000. We do also have Wise Woman clinical services, and I put that on there. I know it's missing from the other two pages because I haven't figured out how to integrate Wise Women into the first two yet, so I'm working backwards. So same thing, clinical services, paying for the cardiovascular screening and behavior change for individual women. That's 11 agencies and $295,000. And then we have the WWC targeted outreach with 7 agencies and $221,000. So these circles really do represent basically the number of agencies involved. The biggest circle, 45 agencies, and then within it, and the circles, they overlap because all of our care coordination and all of our wise women agencies are also WWC clinical services agencies. Targeted outreach, there's a little bit outside because we have 2 of those agencies that aren't WWC clinical services agencies. And then we have a couple agencies that overlap. They do wise women and targeted outreach and care coordination. That's that little circle in the middle. So that's what that's trying to show. But we're going to work really hard to talk about, are we talking about WWC clinical services? Are we talking about WWC care coordination? Are we talking about wise women clinical services? Are we talking about WWC targeted outreach? We're doing it internally. We've confused our contract people a lot. They're like, wait, you just sent me a contract for this. They're like, no, that was clinical services. This is care coordination. And then, of course, we have other important contracts that just didn't fit there. American Cancer Society, Clinical Scholars, working with the Somali Community Center, Ute Mountain Ute. We have 2 medical consultants. We have 2 referral lines. So there are some other things we're doing as well. So any questions on that part, really just really being more explicit with the names of what the WWC is now more than just clinical services. And we just ask for your help in trying to, it's going to take a while to get used to saying that internally and externally to our partners, that kind of thing, because WWC probably will always be clinical services to people, but I think it's helpful to broaden that picture. Any questions or comments?
They're absorbing.
I know. So feel free to, I always am tweaking these things, so if you're like, that doesn't really make sense to me. Everybody here does it all the time. They're like, well, I think that's what this circle one started, totally different. All right. Moving on to NBCCEDP screening provision policies. So you can see they're trying to do it too about. So NBCCEDP, reminder, is National Breast and Cervical Cancer Early Detection Program. That is the program at the Centers for Disease Control and Prevention, or the CDC, that funds where we get our federal funding. So they've recently come out with some, they I believe call them like transitional policies or something, specific to healthcare reform. So we wanted to share those with you and tell you what we're doing and what our plans are for them. All right, so they break it up into policies about the uninsured, policies about the underinsured, and then some data things. So one thing they clarified is that basically the eligibility will remain at or below 250% of the federal poverty level. While that may feel like they didn't really say anything, what they're basically saying is they're not at this time increasing the percentage, the income percentage that's eligible for services. So we don't have to do anything with that, but I just wanted to pass that along. That's a common question about what's happening. And can we see higher income people? So the next is that insurance status should be assessed before any clinical service is provided with CDC funds, and that this includes reassessing insurance status at the time of follow-up or diagnostic services occurring in the same screening cycle. So WWC next steps for this. One thing is this is a little bit different guidance than they previously gave us. This is a more active questioning of the client before you provide a procedure to them. They did clarify on a conference call about it that this was could be self-report. It's not like verifying paper documents. It can be as easy as asking, have you obtained insurance since the last visit, or has your insurance changed? Based on preliminary feedback from some agencies and just conversations we've had, we know that this is not all that hard when the client's coming to you. Many of you are already doing this when they're coming to get their PAP or whatever. But where it gets tricky is if you've referred them to another facility for a mammogram or a biopsy. It's a little bit trickier to figure out who, like, is the subcontractor asking that, and then what happens if their insurance has changed, and kind of what the timing and what that might look like and what the effort is. So we would like to convene a work group of agencies, agency representatives, to kind of talk through some of those things, because you all are more, I mean, obviously you know those intricacies better than what we do of what that might look like. And it'd be good to get a variety of types of providers. And I'll, in a little bit, there's another thing I want to get some providers to provide feedback on, so I might ask for volunteers. Think about if that would be something you'd be willing to help us think through. So that's, again, are agencies already doing this, and what does or could this look like for referrals to subcontractors? Does anyone have initial feedback on this or comments?
Star 6.
Okay. I know that some of these, we've provided feedback to the CDC that some of these are a bit of a change for us, and that it may take us some time to implement it, and they understand that. Okay, so another one is that grantees in the Medicaid expansion states should refer uninsured clients, including lawfully present immigrants, to the health insurance marketplace for assessment of eligibility for expanded Medicaid plans or subsidized marketplace health coverage. So WMC's next steps for this one. We think this policy makes sense, and we know that most agencies are already doing this. You're already checking, either directly checking clients for their eligibility, or you're referring them when they're coming to see you. Maybe you're providing the service but saying, hey, it looks like you might be eligible. So we are planning to redo our Affordable Care Act survey. We did it about a year and a half ago before the ACA was fully implemented, to kind of see what your plans and ideas were. And so we're planning to redo that this fall to really see what has changed, what's going on. And basically we'll move with the assumption that you all are doing this. And it doesn't have to be like you have to have proof that they've gone or that they've, you have their denial letter. And it's not that strict. Some things are, some other programs are more strict, but it's just that you can document that you, yes, referred them. I at least offer that resource to them. And then if there are agencies that aren't doing this, then we can work with those specific agencies to help them implement something like this. And find out what types of referrals are being made. Are you doing it yourselves? That was one of the questions we asked before, so we'll ask it again of, you're doing it on site, there's somewhere else on site, you refer them down the street, that kind of thing. Any comments or questions on this one? So another one about uninsured. Basically, become familiar with the sources and types of health insurance consumer assistance options available in the states, the navigators, in-person assisters, certified application counselors, et cetera. We have done this and will continue to do it, and truly you all know this even better than us, and are many of these things already. Another one that we should report data on any clients that we at least pay for a part of their procedure or test, even if they end up getting Medicaid or insurance. We've always done this, so we'll just continue to do that. Easy, done, check. All right, so this is for underinsured. So payments made by NBCCEDP, or basically our federal funds we give to you, cannot exceed the Medicare reimbursement rate. So for underinsured, this means they have insurance. If the copay or deductible is less than the Medicare rate, then CDC funds may only be used to pay the lower amount. So pay for the copay or the deductible versus the entire Medicare rate. And that CDC funds may not be used to pay for any portion of a test or procedure that would be paid for by another source, i.e. Medicaid under any circumstance. CDC is always the payer of last resort. So this, I have to be honest, is a big change for us because our procedure and process has always been if they are underinsured, if they self-report as underinsured, we treat them basically as if they're uninsured and pay for their services versus paying their copays or deductibles. So I think this one especially is going to take some time to figure out how to implement this kind of change because it is very different than how we've done it. And I've asked the CDC for examples of how other states have done it and have not gotten a lot of examples, but I keep asking. So our next steps are to try to learn about processes of other states that have been successful in implementing this policy, and again, to form a work group of providers to determine an efficient and effective ways that this could be implemented. I think in preliminary discussions, there's some obvious pros of it, of if we're paying towards a deductible versus circumventing their insurance, then it applies, and if they end up having cancer or something, that much more of their deductible has already been met. But definitely I can see some burden in implementing this as well. So I know I've had a couple agencies I've talked to about it when we were at the roadshow volunteer to help me with this. So I'd like to basically form a work group to talk about this one and then the other one, which now I'm not. Oh, that how to assess their insurance status before each procedure. Does anyone want to speak up now and volunteer to help kind of think through this with me? *6 to unmute yourself. Okay.
Emily, this is Dana at Marillac.
Yeah.
And I would be willing to be on the work group for the determining insurance status before the procedures.
Okay. Thank you.
Mm-hmm.
Anybody else for either of those groups?
You can email us.
Yeah, I'll put an ask in the WWC up. But let me know. Email Emily. I think because I really need to better understand what you all are currently doing, what your systems are looking like. This is the same kind of thing where it'd be good to have a variety of providers because I know some initial ideas were, oh, yeah, well, that's easy. We could put WWC as a payer source like an insurance. And so then first we'd bill their insurance and then it would trigger WWC to bill. But I don't know if everybody has that sophisticated of a system. I think there's HIPAA things of, I know some states just have people submit the explanation of benefits showing what they owe, and then the program pays it. It feels like there must be a good way to do it, but I don't know what it is yet.
And what would be the time commitment for an agency to be a part of a work group?
That's a good question. I mean, I think the calls would maybe like an hour per month or something. I mean, just to talk once a month, maybe for the next few months. Again, I told the CDC this is a big change, and it's going to take us a long time to figure out how to implement it.
So it's a good idea to have agencies that really have no capacity to do this and have capacity to do this as well. So agencies that are small and might feel overwhelmed just by hearing this, it's good to have your voice heard during the meetings.
Well, and also, I mean, I think there's some agencies, this would really probably affect agencies that have a lot of that, we have a very, very low underinsured percentage either, and we might be able to look in eCaST and see who has that, but obviously this is probably not Medicaid. This is private insurance, and so this might be people who have a high referred in for diagnostics or a higher private insurance. So we might also look in eCaST, see if we could get a sense of who has this, because it's going to affect you. I know there's some agencies that are like, we don't have anybody who has private insurance, so I don't, you know, Medicaid doesn't have the deductibles and stuff that private insurance does. Any other volunteers or comments? Thank you, Dana, for volunteering. Okay. So do you want to talk about the data requirements that came?
So as Emily said, this is Q, everyone. As Emily gave you an overview of the new policy changes or implementation of policies, of course we have to have data to back that up, either to show that we're already doing it or to collect the data with the new policy changes. So first, I have put together the data requirements from the CDC. For the uninsured, they want to know the number of individuals receiving a program-funded clinical service who are referred to the marketplace for assessment of insurance eligibility in a program year. We know that we are not collecting this at this time, so on the back end, we are looking, so our staff will be looking to edit the existing forms and eCaST to collect this data. Hopefully, it'll be a simple checkbox added to the form and or within eCaST as you are enrolling women into the program. A part of that for the data for the uninsured is of those referred, the number who then return to the program after at least 12 months who are still uninsured. So using the above, we will hopefully have then a benchmark next year. Once we start collecting the data, then if a woman returns, we'll be able to assess who still is uninsured after 12 months. And yes, that's really kind of up in the air right now, but we're working on it, hoping to add a very simple solution for you guys, because you guys already collect so much data that we're hoping to just, you know, put in another checkbox as you enroll women to ask about their insurance status. So that's the first data requirement and what we plan to do to fulfill the new CDC data requirement as part of this program. And then the second CDC requirement is for the underinsured, the number of uninsured served within a program year that received a test or procedure paid with CDC funds. And thank goodness we are already doing this, so we are already collecting this data, and you will not have to remember to ask about another piece of information from a woman as you're enrolling them. So Those are the two. Those are the two new data requirements that are associated with the new policies that Emily talked about earlier. And as always, we'll update you and get your feedback and train you and everything as we implement something new.
Any comments or questions about these data items? Oh, we're a quiet bunch today. Star 6 if you want to comment.
It's a gloomy.
Might not be gloomy also. All right, so the CDC also sent us, this was a different email. This was in February, an updated policy on patient navigation. And they have said this will be effective July 1st, 2015. They are moving away from use of the term case management. Do I have that on the different? Sorry, no. I guess not. All right, I thought I read that. Anyway, the CDC has used case management, and therefore we have used case management. Now they are moving towards calling all of it patient navigation to be more consistent with the terms that are used nationally. Now, that's a tad tricky for us because we differentiate patient navigation from case management, but we'll talk about that in a minute. Anyway, the requirements they have said for patient navigation is written assessment of individual client barriers, individual client education and support, resolution of individual client barriers, client tracking and follow-up, more than one contact with client, and then data collection to monitor the primary outcome. So monitoring if clients are getting screening, testing, and treatment. So our next steps, I'm going to start with the bottom, but I feel like you all are already doing most of those items for both your clinical services and your care coordination clients, but we will evaluate our policies and procedures and make sure, see if any changes are needed. We will be moving towards using patient navigation instead of both patient navigation and case management, but to be honest, case management will not be able to go away until at least 2017 because it's in your contracts. Your contracts say case management. Our toolkit says case management. We have clinical scholar training on case management. So we'll probably move towards using it both, like patient navigation, case management, which will be similar to clinical services, service delivery. But I don't think we'll ever, or it'll take a few years to we won't just be changing.
The norm, yeah.
Yeah. So we'll move towards thinking that way, at least, about that patient navigation is truly through the whole process, not from basically when the woman walks through the door through if she needs treatment or whatever she needs. So any questions on that? Let me be it. So any questions or comments about any of the things covered today? Or do you need any clarification?
Hi, this is Susan at PARS Medical Center. I would be interested in participating in the best practices from other states, and I was just curious if maybe a subset of that exploratory could be maybe looking at some lessons learned of some things some states did wrong. And the only reason I bring that up is because we're very close to Kansas. We have a lot of patients that come from there, and they obviously have not expanded their Medicaid, and so there's a lot of causes a lot of problems for us, actually, for people that want our care, but we can't really, provide it, and just kind of something to keep in mind.
Yeah, no, that I think you would bring a great perspective to that, and I think definitely learning. We always want to we don't want to reinvent any wheels if we don't have to, and we want to learn. We learn from ourselves, but it's even better if we can learn through other people who have already done something. Thank you. I'll contact you, Susan, for that.
And Connie, I just saw your message that says you didn't have the link to the presentation. Sorry, we will send you the presentation.
Yeah, this
as well. She was on the call, but she didn't have the link.
Oh.
She says.
She's on now.
We will post this as always. It's recorded, and we will post it as always. Any other just comments or thoughts or volunteers or random other questions you might have? All right. Well, a quick plug for the 2 remaining road shows. I think the people who've been to them can attest how awesome they are. We will be in Pueblo April 2nd and Fort Morgan April 24th. So if you haven't gone to one of the other 3, go to one of those. Mm-hmm. They are fun, and I think people learn a lot. I did. All right. Well, please feel free to email Chris or Ivy about your numbers and, thinking through, and email me about any of these policy changes if you don't want to be on a group but just have some ideas, or if you have someone I should be talking to at your agency, and maybe you're not the right person but your biller or someone else is, please let me know. And with that, we'll let everybody hang up, and we'll redo attendance.
Everybody.